Welcome back to Mayo Clinic Radio. I'm Dennis Doda.
And I'm Tracy McCrae.
Individualized medicine, also known as personalized medicine or precision medicine, means tailoring the diagnosis and the treatment to each patient to optimize their care.
Using a person's unique genetic code, researchers and healthcare providers can more effectively and precisely diagnose, treat, predict, and eventually prevent disease. Here to discuss is the director of the Center for Individualized Medicine at Mayo Clinic, Dr. Keith Stewart. Welcome back to the program, Dr. Stewart. It's great to see you.
Good morning, and thanks for having me back.
You know, we've been hearing precision medicine and individualized medicine more over the last year or two, but it was kind of a new term. When did this really begin as an effective medical tool?
Well, the first human genome was sequenced in about 2001, but it really didn't become part of our capabilities to use this clinically until the price dropped to something more affordable. The Center for Individualized Medicine at Mayo Clinic was started 5 years ago, just past the 5-year mark, and that really marked the introduction of building the infrastructure to allow us to introduce this clinically, which is now our sole focus.
Is it moving at a quick pace, or is it taking baby steps?
Well, the technology advancement is remarkable. The first genome cost close to $1 billion for one genome.
Oh, wow.
Now it's only probably around $1,000 to do this, at least as a research tool. Clinically, there are genetic tests available for a few $100s.
You know, folks may see advertisements for direct-to-consumer genetic testing. Are those good, and what would they be used for effectively?
So there's a democratization of genomics, I'd like to say. It's something that's expanding out into the public awareness, and consumers are interested in it. The major dominant player in the direct-to-consumer marketplace is 23andMe. Until recently, that was what we would call recreational genomics. It was to find out interesting things about yourself and your family and maybe your environment. A fairly important step in the last year, however, has been that the FDA has now allowed 23andMe and other companies now to come in and offer what we would call real medical screening tests. So you can be screened for specific conditions using, without the doctor being involved. But I want to emphasize those are screening tests, and if you want to confirm that the diagnosis is correct, you probably need to go to a regular lab.
Well, and wouldn't a genetic counselor be a key piece in that? Because if you are going to go from, I just want to find out where my family's from, what part of Scotland they're from, to do I have an increased chance of breast cancer, you're going to want a genetic counselor to be part of that. And is that area expanding as equally?
Well, this is still very heavily regulated by the FDA, and so the testing that is allowed are tests that are medically relevant but not necessarily ones in which you would need genetic counseling. So things like celiac disease, for example, would be a good test. A lot of people are interested in gluten sensitivity, and you can test to see, do you really have gluten sensitivity or not? You don't need a genetic counselor for that because it's not going to impact other members of your family probably, or at least if it does, it's not a tremendously serious problem. On the other hand, things like breast cancer testing are very highly regulated. They're not available as a direct-to-consumer test today. A physician and possibly genetic counselor still needs to be involved.
What about the pharmacogenomics piece? Is that part of something that you can find in direct-to-consumer testing?
Again, the answer is no.
Okay.
Again, because the FDA is concerned quite rightly that if you are told information about what drugs you can and can't take, you may unnecessarily stop a medication or you may avoid taking one, and unless that is really very accurate information, that could be harmful. So you can't really offer drug gene testing to consumers today, unless it's an over-the-counter drug like drugs that you take for heartburn, indigestion, or anti-inflammatories. You can test for those, and probably the FDA would allow that, but not for things like anesthetics or painkillers or drugs where there might be adverse events.
Are there some other applications for pharmacogenomics? That sounds like a big fancy term, and you equated it to drug testing. How do you test for that? How do I know if my body's making the right things to process drugs that I may be given?
So this is a big deal. It's estimated there are 1.5 million adverse drug events and 100,000 deaths every year in the United States from prescription drugs. All of us are born with certain variations in the genes that we inherit from our parents, which are responsible for metabolism of drugs. So some people will metabolize drugs slowly, some will metabolize them more quickly, which means they may need a higher or a lower dose of each drug. So that pharmacogenomics is the test of those genes you're born with, how they influence the prescription drugs that you take, and as a guidance to your physician to be more careful, avoid completely, or use at will certain drugs. And we think by implementing that on a wide scale, we will reduce the number of adverse drug events and make drug safety a priority for our patients.
I just have to tell you, Dennis, the last prescription that I was given, I said to my doctor, as part of a study that I was in, I have some pharmacogenomics information in my folder, and it was affected. One of the drug that they were going to prescribe to me was something that was affected by my genome. I was an under-metabolizer of it.
And I had it done on myself, and I always tell people I would not take another prescription drug without consulting that list the rest of my life. And of course, it never changes through your whole life. And right now, the test we're offering is only in the $250 to $300 range. It's relatively cheap. Covers 450 prescription drugs. We think it should be part of the routine care of all of our patients eventually.
It seems to me from interviews that we do about genomics that possibly this is going to be expanding the fastest, the pharmacogenomics piece. Am I getting that right or no?
Well, it's certainly in the area of predictive genomics and healthy genomes. It's the low-hanging fruit. We think it's important.
Right.
We think it's useful. It's not very expensive. It's got physicians are interested in it. We think patients will find it valuable. So yes, we think that's probably one of the early entry points. There are other areas like cancer where it's already really become part of clinical practice.
Should everyone be tested, or are there certain individuals for whom you would recommend this as a priority?
Well, for drug gene testing, you
yes,
mean?
please.
I personally believe everybody should be tested one day. The value of doing that still has to be proven. We want to make sure that we do have a positive impact, less drug adverse events, more efficacious outcomes. We don't want to do unnecessary testing which doesn't help. So we still need to, there's some proof still required. But I do believe that eventually everybody will have this done.
Let's talk about where research and patient care come together. So how do the advances in research make it into how patients are being treated?
Well, this all starts as research, of course. The reason that pharmacogenomics or drug-gene interactions are prevalent in our thinking at Mayo Clinic is we've had a very strong research program in this for many years, and so it has become easy for us to capitalize on that and advance it into the clinic. But there are other areas today that we're interested in expanding into. One might be inherited cancer, for example. It's estimated that 5 to 10% of all cancers have an inherited basis. Most cancer centers don't routinely test patients for that, yet it would impact not just those patients, 1 in 10, 1 in 20 patients, but also all of their family members. We have very strong research in this here at the clinic. Doctors like Dr. Fergus Couch, who's a world authority on the genes that put you at risk for breast cancer. We've been able to capitalize on that. We think this is something we should offer all of our cancer patients. So that will read directly from the research we've been doing into our clinical practice as one example.
What's the latest on the All of Us program? Tell people what that is and where does that stand?
Yes, thank you for asking. President Obama announced in 2015 an initiative to collect samples, bodily samples, blood and urine from 1 million Americans, representing the diversity of the population around the country. The idea is that it was now named the All of Us program, and I think it's important to note it's got bipartisan support in Washington, which is one of the few things it does these days. Continues to have bipartisan support and funding. Mayo Clinic was selected to be the biobank or biorepository for those 1 million patient samples, which will be 35 million tubes of blood and urine. The idea is they will all have the genome of those individuals sequenced, and they will be followed over many years to better understand the value or not of sequencing genomes on a sort of population scale.
We've been talking about individualized medicine with the director of Mayo Clinic's Center for Individualized Medicine, Dr. Keith Stewart. We're going to take a short break.
And when we come back, Dr. Stewart is going to preview for us the upcoming Mayo Clinic Conference, Individualizing Medicine 2017.
You're listening to Mayo Clinic Radio on the Mayo Clinic News Network.
Welcome back to Mayo Clinic Radio. I'm Dennis Doda.
And I'm Tracy McCrae. Next week, Mayo Clinic will host the Individualizing Medicine Conference, bringing presenters from around the world to speak on genomics and personalized medicine topics.
And we are lucky enough today to be talking with the director of the Mayo Clinic Center for Individualized Medicine, Dr. Keith Stewart, who will open the conference with a session titled Clinical Implementation of Genomics, the Story So Far.
So, Dr. Stewart, what's the story so far? Give us a little peek into the talk you're going to be giving on Saturday.
Well, I was stimulated to give this title because I, like everybody, I'm on Twitter these days, and I saw somebody that tweeted, personalized medicine isn't there yet clinically, and I thought, well, that's not right. So I decided the focus of my talk will be demonstrating that, in fact, personalized medicine, individualized medicine has become part of our routine clinical practice in cancer, in diagnosing rare diseases, which are probably inherited, and more even in healthy people. So the focus of my talk is how we're implementing this into the Mayo Clinic bedside practice.
As far as experts from Mayo Clinic or from elsewhere in the world, are there some presenters and their topics that you're most excited about?
I'm very excited about all of our presenters. We've got a star faculty coming in. They're going to talk about all kinds of different elements of this. Some highlights, perhaps, we have scientist Dr. Ledbetter coming from Geisinger Healthcare System. They have sequenced the genomes of 250,000 patients.
Wow.
They've been extending those results, and they're publishing in the world's top science journals of the impact of that and what it means for their patients. We have representatives from the National Institute of Health coming to talk to us about the All of Us 1 million American cohort that is being launched and is now underway. We have experts in the microbiome coming to talk to you about how the bugs that you live with every day impact the genes that you're born with and how they work together and how that influences your health. And some little more niche products which I think are fascinating, like can genetics help you avoid smoking or prevent smoking addiction, is one of our speakers, which I think will be fascinating.
You just said a buzzword that I love to talk about, which is the microbiome. So because your microbiome has its own genetics, correct?
Of course, we live with 1 trillion bacteria in our bodies every day that live in symbiosis with us. They live together happily, but they each have their own genome, and they are doing their own thing, and they're producing their own chemicals. And there are a lot of literature emerging that has impact on the drugs you take and how they're absorbed, on weight gain and appetite and diet, on even unexpected things like cardiac disease and inflammation.
So when I hear that, I think, all right, I've got my genetics. I can't change my genome. My bugs, my biome has got its genetics. It can't be changed.
Well, it can potentially. I mean, antibiotics change it in maybe not good ways.
But antibiotics don't change my biome. They just change my microbiomes. They don't change my genetics. They change my microbiome's genetics.
So I think I always remember the cover of Time magazine I use in my presentation. DNA is not your destiny was the title. So genomics impact a lot of what you are and what you become, but the environment is also critical. Where you live, what you eat, how you exercise, whether you smoke or not, all of these things impact you. Part of that impact are the microbes that you live with, that you probably carry with you from house to house, and that's been shown. It's more to do with the people that carry them than the environment. And it turns out that they have an important role to play in modifying how your genetics interplay with your health.
All right. People hear biopsy, where you take a small sample of tissue to study that in the laboratory. Right. You have, in the past, used this term liquid biopsy. That is fascinating.
Yeah, we're very high on this area. This is the concept of taking a blood test to detect cancer. And that can fall into two particular uses. The one that is probably most exciting is the idea of a pan-cancer blood test, so that once a year, perhaps, particularly if you're at high risk, we would take a blood sample to see if you have cancer.
Pancreatic cancer?
Any cancer.
Any cancer?
In theory. And we think that's a very exciting concept. In fact, we're partnering with a biotech company.
That's kind of an understatement.
Yeah. Well, this company raised a lot of money around this concept too, and we've been delighted to partner with them in a study which will enroll 120,000 women who are having a mammogram. We will take a blood sample from those women at the time of mammogram. We'll see if we can detect, using the blood test, the cancer that the mammography finds, or maybe even enhance the sensitivity of that testing. The second way you can use a liquid biopsy is once you know you have cancer, if you can monitor it in the blood through a blood test instead of doing x-rays and biopsies, which are deep in the body, that will make life much more efficient, much less risk of harm, and a new way really to monitor the presence, response to treatment, and recurrence of cancer using a blood test. So we're pretty excited about the potential.
I can see why.
If you've been able to do this with a blood test all of this time, how come we're just starting to do this now?
Well, we haven't been able to do it all of this time. In fact, we still can't do it.
Well, we've had blood. We've been doing blood draws.
Yeah, but we haven't had the ability to look. So with the sample I talked about, where we're going to look at these 120,000 women getting mammograms, I think it's almost like sending a deep sea submersible down deeper than anybody's ever gone and seeing what life is down there. It's a bit like that. We don't know what's in there. We may all have cancer all the time. We don't know until we go deep enough and we look carefully enough. We haven't had the sensitivity of technology until very recently to do that, and the cost has not been compatible with doing this on a wide scale until recently.
If women, that's the Strive study that you're speaking of. If women want to be part of the Strive study, because we all are getting our mammograms, and they don't live near a center like Mayo Clinic campus, how can they do this? If they're in different parts of the country, can you request to be part of the Strive study?
The centers that run it are Sutter Health in California and Mayo Clinic, all three of our campuses in Phoenix, Scottsdale, Jacksonville and Rochester, as well as our healthcare system in Eau Claire and La Crosse. And I think anybody that's interested could contact one of those centers and arrange to have their mammography there. And all women who come for mammography will be asked if they want to participate in this study.
We have 1 minute left. Can you tell us what is on the horizon for precision medicine, individualized medicine?
Well, we think that if you ask us what our major initiatives going forward in the next year are, it's inherited cancer, moving into that area to get its liquid biopsy we've already talked about. One we haven't mentioned is perhaps the personalization of cancer therapy through immunotherapy. Trying to understand how we can harness the patient's own immune system. There's nothing more personalized than getting your own genetically engineered cells delivered back to treat your cancer. That's one area. Sequencing the genome of all Americans and all patients, all healthy people, I think is really our medium-term goal, where I think that personally that there's so much to be learned. This is a resource for your life. It's not a one-and-done test that we should, and it's not that expensive. That I suspect that's our future.
Wow. Well, thank you for sharing so many of these insights with us and giving us a little bit more understanding about it. We've been talking with Dr. Keith Stewart, previewing the upcoming Individualizing Medicine Conference. It's taking place October 9th and 10th in Rochester, Minnesota. Dr. Stewart, by the way, is director of the Center for Individualized Medicine at Mayo Clinic. Dr. Stewart, thank you so much for being here.
It's been great fun. Thank you.